Good evening, all. I welcome all of you in this Diagnostic Day-4-A. And it is based on one very interesting, relevant, although little difficult topic, that is artificial intelligence. Now the question is, why we need artificial intelligence? See, these days we are generating so much data, and as a laboratory person, it is our responsibility to reproduce a report with correctness as much as possible. What is the expectation of clinician? They expect correct report, a meaningful report within reasonable time frame. And whatever we do in our laboratory, we want to ensure these two things. Now, when we are generating so much data, such a complex testing, we are carrying out this flow cytometry, we are carrying out immunohistochemistry, genomic testing, and we have to interpret all this data. And sometimes machines suggest us something. What is the basis of that? Machine is able to interpret on our behalf. How many of you have heard about this artificial intelligence? Please write in the chat box. And the simplest application of this artificial intelligence is, in your laboratory, you can see your Levin-Jennings charts. Previously, what used to happen? We used to run control, and after running control, we used to make this Levin-Jennings chart on a graph paper. Now, machine is carrying out this activity for us. Machine is telling us whether it is beyond 3 standard deviation, or it is beyond 2 standard deviation. How machine is telling us? Through some mechanism. We are using intelligence of machine for our work. So this is artificial intelligence. So that way it has many applications. And if you see whether it not only medicine, everywhere, this Novak Djokovic, a famous lawn tennis player, he used artificial intelligence to improve his game, to practice for the Wimbledon. Many of you must have heard about this. Anil Kumble, famous cricket player and engineer by profession, although later on his main profession was, you can say, cricket, he also used artificial intelligence to improve his game. Similarly, in table tennis also, there is application of artificial intelligence. It has application in the forensics also, in the face recognition, in the fingerprint recognition. That way it has application in many other industries, many other areas. So we have to understand, and now everybody these days talking about digitalization. Government is also saying we have to develop digital India. And in our laboratory, we have seen, we talk about automation. Automation is helping us tremendously. But what is important? We have to understand what is this automation and what are its limitations, what are its advantages. Whenever we are developing a new thing, in addition to advantages, we should learn about its limitations also. And now we are talking about this artificial intelligence. We will see what exactly it is. We have to understand what this artificial intelligence is good for. That means what are its uses and what are its applications, what are the areas where we can apply this. And it is very important when we are applying this artificial intelligence, how to evaluate whether it is really serving some purpose or not. And when we are evaluating, we have to understand its limitation also. Therefore, it is very important to know. One thing is concept of this artificial intelligence. and how we can apply, because now Dr. Preethi Chari and Dr. Rajan Verma will discuss, Dr. Preethi Chari will discuss how we can use this in identifying various type of cells. So how this is implemented, and when we are implementing this, what are its limitations? But problem is, this is an evolving field which is at present not well understood, because when we read, and generally what is our perception? This person is engineer and he will see engineering, and in this there is a lot of concepts which are not related directly to patient care. So this is something which we cannot understand. Some engineer is required to understand this. This is something related to medical. For this, a person with medical background is required. Now, this clear-cut borders, these are disappearing. Engineers and doctors or people from the medical field, they have to work together. Only then we can create advancements in our diagnostics, in our therapeutics, which we can use in the better patient care. There are two terms. One is artificial, another is intelligence. Artificial is something which is made by us and not occurring naturally. Or you can say made by us, which is copy of something which is occurring naturally. So that means it is not something which is occurring naturally. And what is intelligence? It is the ability to learn, to understand, and to interact with one's environment. That means ability to acquire knowledge and apply this knowledge. When we ourselves are applying this knowledge, then it is natural intelligence. And when machine is carrying out this activity for us, this is, we are using the intelligence of machine, then it is called artificial intelligence. So for this, we have to design some machines, or you can say some agent, which are thinking on behalf of us. This term was coined by John McCarthy in 1955, when he said, artificial intelligence, it is the science and engineering of making intelligent machines. So therefore, we are developing machines which can think on our behalf. And this field was founded on the claim that a central ability of human intelligence can be simulated, can be copied. These machines are thinking on our behalf. You must have heard about this robotic surgery also. They are performing surgery, and role of robots in various other fields. These are the different fields: deduction, reasoning and problem solving, knowledge representation, planning, where we can use this artificial intelligence, and learning about the concept, natural language processing, motion and manipulation, perception, social intelligence, creativity, general intelligence. We use all these terminology when we talk about artificial intelligence. These are the different other terms. These are called tools. These are the concepts which we use in artificial intelligence. One thing is optimization, logic, probabilistic methods for uncertain reasoning, classifiers and statistical learning methods. In this, there is, in certain areas, outcome is numerical. In certain areas, outcome is classification, neural network, deep neural network, superficial neural network. We will understand all these things. And this is just the beginning. Certain things we will discuss in this program, but you can say this is sensitization program. And with more programs, we will develop our understanding when you will gain knowledge through this program, when you will start reading from the references, definitely the knowledge will improve. What are the different languages? Sometimes people say you learn Python language. That is okay. But first thing is understanding of concepts and what are its applications, and you are evaluating how we can further progress in this field, how we can find areas of this artificial intelligence. It has application in finance, hospitals, medical laboratory, other industries, transportation, in video games, in military, in space science, in music, in sports. It has various applications. In our medical laboratory, it helps us in more accurate detection of pathology. How? That we will see in the coming lectures. Better laboratory or optimized laboratory workflow, improved decision support, reduced cost leading to higher efficiencies, effective use of resources, avoiding unnecessary tests, patient safety, alerting for abnormal results, identification of variants in molecular testing. It helps us in HPLC also. What are the advantages? We are able to simulate human behavior and cognitive processes. We can capture and preserve human expertise. There is fast response, and we can analyze large amount of data quickly. But it has limitations. It will analyze based on the inputs. It has no common sense, cannot readily deal with mixed knowledge. An initial cost when you are developing something, that cost may be very high. But it is required in the present time. It supplements natural intelligence. We are building intelligence in an object so that it can do what we want it to do. We have to program these machines so that they can perform activity as per our desire. And when this machine will work as per our input, human mistakes will be reduced because human labor is not involved. But you have to keep in mind one thing which is very important. Whatever data we are generating in our laboratory, that is input, that data should be as accurate as possible because they will analyze that data. Future of the artificial intelligence is, you will find decrease in the healthcare expenditure. It will reduce or it will replace manual labor. In laboratory, we will find more efficiency and decrease in the cost. Rapid increase in it is gaining importance. It will help us in the process improvement, and it will also help us in the diagnosis. And in the future, this technology will help us in developing more newer tests and in identifying role of the existing test in the better patient care. In precision medicine also, it has definite role, and in the coming time, it will become integral concept of the healthcare. If you are planning to implement artificial intelligence in laboratory medicine, what is required? One thing is education. First, we have to understand this artificial intelligence, and this shall be incorporated in the medical education, in the UG teaching, in the PG teaching, so that it becomes integral part of the education, so that when a person is passing his or her MBBS or post graduation, the the person has knowledge of this artificial intelligence, then what are its application in the various fields? How a surgeon will be benefited by this artificial intelligence? How a pathologist, a microbiologist, a biochemist, for that matter, anybody working in the healthcare will be benefited by the implementation of this artificial intelligence. That has to realize, and a lot of research is required. At present, it is just the beginning. How we can generate accurate inputs, and then what are the new areas where this artificial intelligence can be applied, so that we can apply this in many areas and we can help in the better patient care.
As far as the topic is concerned, I think you know, and some of my close friends and colleagues are well aware that this is perhaps one of my favorite topics because it's an evolving topic. Yes, it's an evolving topic, and it has taken gained a lot of importance and in the diagnostic space in the recent past, at least in the last 4 or 5 years, and not at the desired pace or speed at which some of the application specialists wanted to. But then it obviously has started allowing people to think about moving into an automated AI-driven digital platform for reporting. And how it works, of course, you have very beautifully explained. I'm sure everyone has a very good idea that this is not about replacing our intelligence, or it's not about replacing pathologists as most people fear or talk about in various meetings and forums. I mean, there's just this general myth that AI is going to replace the human efforts and human skill and stuff like that, which is a total myth. Because first of all, the machine learning, in the first place, if you understand how the engineering works and how the software development works, then you'll realize that the human effort is even more important in making that happen, and on the engineering side of things, and how we utilize a software of that nature in our daily workflow to make it more efficient, to make it more cost effective, to make it more accurate in terms of reporting and save more time, etc., etc. There's like various uses depending on how we utilize it. So let's start with how we use artificial intelligence in hematopathology. And I think the more common terminology would be, something that we always refer to in the context of laboratory medicine, is the digital platform. And we'll see how that is. The talk flow and the talk plan for today is, we'll first discuss how in hematology, what our routine workflow is like, and what is exactly whole slide imaging and machine learning and artificial intelligence, and how we can utilize that to capture data from our routine work and train a model which will allow us to use a digitized platform for reporting. We'll see how we use it in real life through some case discussions, and then what we have to take home as a conclusion at the end of this discussion. So we all know that workflow and routine hematology is, basically our CBCs, which form the bulk of our reporting in any laboratory for that matter, whether it's a small lab or a big lab or a hospital. We know that one of the common tests asked for is a CBC, and it roughly constitutes about 30% to anywhere between say 25 to 50% of the test requests that we get on a routine day. And what we're trying to achieve through CBC reporting is we try to count the RBCs, WBCs, platelets, and see if there are hemoparasites. At a very high level, that's what we're trying to do. We're looking at the counts, and perhaps when there is a blood picture, we try to morphologically analyze these cells. So it is an important screening tool for absolutely various conditions, like, various clinical conditions like infections, inflammation, anemias, leukemias, whatnot, whether you're taking drugs or chemo, follow-up, etc. So we have CBCs being done day in and day out, and the context of asking for a CBC can be anywhere between a basic health check where the patient is absolutely clinically normal to a, a pre or post chemotherapeutic evaluation where we're trying to look for certain specific morphological abnormalities. And in a standard laboratory, we either have a 3-part or a 5 or 6 or 7-part cell particle analyzer for WBCs for the cells. And what we normally do is the sample that we get, we run it through the analyzer and we look at the values. If it's a 5-part analyzer, we know that if there are no flags, we can just go ahead and authenticate or verify the report, which is what we do. But if the counts are abnormal, and now when I say these counts are abnormal, there is a bigger science that goes into understanding our analyzers as well, which is not going to be covered in this particular topic. But like every other automated instrument that gives you that analyzes samples for you, you have to understand how it works, you have to understand its limitations, you have to understand the clinical context for the patient, etc., etc. So when we see abnormal counts or flags, as per the slide review criteria that we have developed for our lab, whether it is through some kind of an international guideline based criteria or a lab derived criteria, we set up rules and we decide to make and review smears under the microscope, and then we authenticate the report based on what we see. So this is on a high level. I'm sure every single person on this forum would agree that this is how we go about analyzing CBCs. And the cells are obviously very important. There is more history and geography and clinical relevance for each of these cells. And WBC analyzer, when we analyze it through the cell counter, it gives us a lot of morphological clues. So even there, it's important to know your machine, whether it's working through an impedance or a flow cytometry kind of principle, and look for the data that you get out of it. Look at the raw data and understand whether it's giving you clues on what type of abnormality we're looking at, a count-based or morphology-based or both. And we try to enumerate and better understand the distribution of the 5 types of WBCs and also perhaps some abnormal WBCs if they're present. And these are the various raw data that go into reporting. We look at the graph, we look at the histogram, we look at the cells, and finally come to a kind of a conclusion. And we follow a certain level of criteria, which is quite standard. And especially if it's an NABL accredited laboratory, we have to be more cautious on what kind of review criteria we're using. And we also have critical alerts and panic alerts that have to be defined, and that also carry a lot of weightage and importance while reporting, because you have to make a specific call to the patient or the clinician, informing them about the extremely high or low values. And so these are the various touch points that go into a smear review. And what I'm trying to perhaps emphasize here is, okay, we'll finish RBCs and come to that. So RBCs, when we're looking at RBCs, we're trying to analyze the RBCs size, shape, and inclusions. By and large, that is how we're trying to categorize. And if we go deeper into each of these, we'll realize that the sizes, like, whether they are normochromic, microcytic, hypochromic, microcytic, normocytic, or macrocytic, and then whether they are normochromic, and then the poikilocytes, like the various types of RBC shapes, and then trying to quantify each of them, and in combination and collating all of this, what we see, we try to arrive at some kind of a diagnosis, and also to see if there are inclusions. So slide review criteria for RBCs is also important. And one of the major challenges in slide interpretation is it is very time consuming. So when I say time consuming, I mean not for all the slides, but we do know that when we are reviewing, we have to pay a lot of attention because we don't always know or have adequate information on the patient's clinical side of things. And so your mind is sort of not always ready to capture the intricate and maybe subtle clues that there are on the smear. I mean, a good pathologist, and I think you'd all agree, has to review all the cells and look at the background, look at the entire slide, do a proper differential count, correlate it with the graph and the values that the cell counter has provided. Look for malaria, which is always not easy to find, especially the staining is not proper. Look for RBC inclusions, which is very difficult again because like how will jolly bodies and so many other inclusions which can look like just platelets sitting on the RBCs, or it can look like artifacts. So it's not always easy, but CBC again being one of the most common tests, you have to understand that it carries a lot of weightage and value. So if you're going to give that extra information to your, to your doctor or the patient, then they'll know what to do with that as a next step to decide what should be done. For instance, a simple WBC analysis, morphology of WBCs will give you an understanding whether there is a viral infection or a bacterial infection, whether it looks like infectious mononucleosis or whether it's a leukemia. So morphology plays an extremely critical role, and a trained pair of eyes with a lot of experience usually tend to pick up a lot of information on CBCs. Um, so let's just generally talk about the ideal versus the real world. Ideally, we need skilled and trained technicians. We need skilled pathologists around the clock. We need access to slides anytime and everywhere. But what's reality is we don't have all of that. And to some extent, by having a digitized platform, we'll see how some of these problems can get solved. Now, what is the meaning of WSI and machine learning and artificial intelligence? I think Sir has gone through it in detail. I'm going to just take a couple of minutes, or perhaps lesser, to, to get an idea of, in the laboratory context of things, there are two main terminologies and software understanding that you need to have when we're talking about digital pathology. So I'm sure all of you have heard the word digital pathology and people using it, and perhaps only the affordable labs have it, etc., etc. But what is WSI? So WSI, I think in the next talk especially becomes even more relevant in histopathology. What you see is basically a thumbnail impression of an entire section or an entire section of tissue or of some biopsy. It could be a gastric biopsy or a prostatic biopsy, whatever. The entire stained section of that particular slide has been thoroughly scanned using a scanner, and it is now available on a computer screen with a software capability that will allow you to navigate the slide the way you would have done on your microscope. So what that typically means is you will be presented with this kind of a slide or an image on your computer screen. You can zoom in or out. You can move your cursor to a relevant area where you think there are suspicious cells. You can magnify them. You can gate them. I mean, or you can just box them in case you're interested and you want to come back. You can save pictures. You can do a lot of analysis with only whole slide imaging. Now, this concept is very important because this is the first step that happens even before we go into artificial intelligence and using an algorithm or deep learning to get insights through the machine. So this is a very basic scanning of a slide, that is a stained slide that is available in our lab, and making it available to us on a computer to be able to view them remotely, either locally or remotely, but instead of on the microscope. Now, why is that important? One can ask. And the first thing that comes to my mind is you will be able to view the slide wherever you want. So you don't have to always be physically co-located with it, which means if I have an advantage of being able to see something, I'm an expert in, say, nephropathology, but I don't have the slide with me and somebody wants to show it to me, or the other way around, I have a slide and I don't have a nephropathologist and I want to share it with them. This is pretty much the best way and fastest way to do it. We're not wasting anybody's time, and we'll also be able to, get a quick, accurate, expertise-based, reporting much faster. So you can just imagine what that means for the patient or for the clinician. So that's far by, it is the most important use of a WSI. And besides that, the whole world is talking about data collection. So the more data you have, the more you collect, the better you store it. You don't know how and in what shape and form you can use it at a later time, for yourself. For maybe just as simple as a training session or a teaching session where you can just take these images, or for medical legal cases, or for sharing images between colleagues, between experts, and whatnot. So there is an immense use for data, and you'd agree that it's far better than storing these slides under horrible conditions with storage space issues in laboratories for 10 years, and the patient comes back after 5 years and they want you to somehow review or somehow retrieve the slide for them, and you don't know where to look for them, or you can't find them, or you find them but then they've lost their quality. So all of that is solved by this one particular feature that a software can provide for us. Now we extrapolate further, and then we go into what's the next segment of this whole digital platform is the machine learning and the deep learning, or the artificial intelligence. While we won't go into how it works, and even I'm not entirely aware because I'm not an engineer, but what I do know is there's enough, like Sir said, there is a deep neural network which mimics, the idea is to simulate how the brain works, and you feed it with a data set. So you have a large data, you want to train your instrument. The simplest example over here I can give you is I have a large data set of normal looking neutrophils, lymphocytes, monocytes, basophils, and eosinophils. I'm going to put all of them or run them. I have 10,000 such cells. I'm going to run them by this particular neural network or the deep learning algorithm, and train the machine or the software to tell it that this is how my neutrophil in a normal condition looks, etc., etc. And now the machine is able to understand that this is how I am supposed to interpret these cells. And then I start putting more or feeding more and more such cells real time, so that the model keeps improving. And finally, the output layer is where the learned, or the network is able to give you, or the algorithm is able to solve for you by annotating, or by itself identifying the answers, or what do you call it, identification of the cells in this case on its own. And this is just a paper on a few years back, when I was working in Anand Lab, where Dr. Sujay and myself had worked with a company that used machine learning for artificial intelligence for building a software. And so while we just saw what the science behind this is, we'll see quickly how the image capture happens, and what the machine does back end. Again, these are all not relevant to the pathologist when they're reporting, but this is a science that you need to understand, and you need to understand what goes into it, and what is the difference largely between a digitized or a scanned image versus a digitized image with a software that's able to give you AI-based reporting. So for WBCs, there is the machine there is a hardware and then there is a software. You send the stained slide through the machine. The machine is able to identify a start point and an end point, just the way we would use the last 1/3 of the slide smear to review. It will start grabbing all the images. So there is a camera basically, and the camera will, as the robotic arm takes the camera and the eyepiece of the microscope around the area of interest, it will capture continuously images, and then it will just stitch them together. And this is the technique. Once the start and the end points are established, the WBC monolayers for the cells according to the battlement track pattern, which is what we use, and the coordinates are stored. When the number of cells ordered have been found or the endpoint is reached, it stops. For instance, I just feed into the software that I want 500 WBCs to be counted. So it is going to keep scanning till it finds 500 WBCs, and then it's going to stop scanning. And now those 500 images that it has picked up, it's going to start extracting them, and it is going to start classifying them, because this is already learned. It has already learned that this goes into neutrophils, this goes into monocytes, this goes into lymphocyte, and then it classifies. And while it's doing, it's continuously checking for focus under 100x, because we want well magnified and well captured images. And these are the various technical steps that happen while the image is being extracted and focused and segmented, and the features of each of the cells are extracted from the interest area. And finally, like I showed you, the input comes from all the cells, the extracted features from the different types of cells. A machine learning happens, and finally, as an output, we are able to not only get the extracted image in different classes. For instance, okay, this is just a very simplified and a nice way of putting what exactly happens during the image capture system and the image extraction system. And finally, a compressed image is available on the software, on the user interface for you to review on your computer. So what you get at the end of the slide scanning and the machine learning is you're able to get a report which the software has analyzed, and it's telling you that neutrophils are so many, monocytes are so many, lymphocytes are so many, eosinophils are so many, and gives you a report. Now you have, instead of a slide, you have this computer to analyze. If you want to reclassify, you can reclassify. You can put, in case you feel that there is a misclassification, you can always reclassify them. And finally, you have a data set of images with you, and you also have a report backing it, or backed by the images that will validate, help you quickly validate your smear and report it. A very similar protocol is employed for RBCs as well, where the monolayer is, the scanner tries to identify a certain area. It captures images, it tries to characterize the images, it studies the RBCs, it tries to bucketize them into different different types depending on the shapes and the sizes. And what you'll ultimately see is, you can see the WSI, which means that you can see the entire image. If you don't want to regard this, you say, for instance, you're not very happy with the report it's giving you, you still have the image available on your computer, and you have every leeway and the freedom to interpret it the way you want. Or you can extrapolate from the the information panel or the side panel, which gives you all the sizes, shapes, color, hue, inclusions, parasites, everything. So everything is classified, everything is available for you. All you have to do is, in the click of a button, decide whether it's all right or wrong, or reclassify if required, and move on. This is the user interface for RBCs. And these are some of the, again, a part of the user interface which allows you to interpret and, if required, even set grading systems into your tool to say that this is a threshold. If I have polychromatic cells from 1 to 5, then you can grade it as +1. If it is 5 to 10, then you can grade it as +2, so, or 2 plus. So depending on how you want how tight you want to keep your criteria, you can set it in the rule book, which is available in the back end of the software. And this is how the report looks. I'm not going to go too much into which company and what platform it is, because it's all available on the internet. The idea is not to promote any specific software tool that is available in the market, but I think the idea is of this particular session is to understand how we can use the science that there is today to improve our reporting mechanisms. So if we have to redefine the workflow, we go back and make a small change here, that instead of reviewing the smear under the microscope, we review it using a cell morphology analyzer, and then we authenticate it. And how we actually do it, and some of these cases have been directly reported, I think. Yeah, we have another 10 minutes, so I'll quickly run through the cases. We'll see how we can actually use them in our day-to-day reporting. So this is a case of suspected case of TMA. And we all know that, first of all, there is a challenge on identification of schistocytes, even on a well-stained smear, because it has its own criteria in identification. And there are various papers telling you how a schistocyte should be identified and how it looks. And not only that, it also tells you that these many number of schistocytes have to be present before calling something clinically a microangiopathy. So if that's how strict our guidelines are, then just imagine, I mean, this is again one of my first cases to show you, because I know in my practice that although we all identify, I mean, fairly good pathologists are always able to identify schistocytes, but the repeatability is always very poor, because trying to quantify schistocytes and give your clinician a report saying there are 2% schistocytes or 1% schistocytes, it's not always repeatable, it's not always easy, it's very challenging, and the poor repeatability can lead to poor decision making in the clinical setup. And I think pathologists are largely responsible in making sure that that doesn't happen. And this is one place where quantifying and doing a differential count for RBCs, which we don't do in common practice because it's practically impossible. And I think we'd go mad if we started actually doing a differential count on RBCs. But just look at this particular slide. It gives you a quantification or a quantity of the abnormal shapes that are present on this particular smear. And in this case, the poikilocytes is about 2 or 3 plus, and it's also telling you that there are a lot of schistocytes. And it's also telling you that there are some inclusions like basophilic stippling and Pappenheimer bodies, which I may want to disregard because they may not always be accurate. So again, this is where it's using its artificial intelligence to tell you that these are the likelihood of what your report, what your cell types are, and your report has to say. But you have to use your common sense and natural intelligence, and probably your also some amount of practice in the field of pathology reporting or hematology reporting to know what to regard and what to disregard and what to include in your reporting. So this is again another view of the same case where it allows you to just put all the schistocytes in one image folder. And also you can just click on schistocyte and only those cells will light up. And then now here, if I decide that some of these cells are actually not schistocyte, they're just, like kind of broken or fragmented RBCs, I can go ahead and do that. The idea is it gives you the complete, you can be the pilot. It is only aiding you in reporting. And like I just mentioned that ICSH defines standardized morphological criteria for schistocyte recognition, and quantification of schistocytes with very good accuracy and repeatability is what a digital platform with image analysis can actually give you. The second case is of a hemolytic anemia. Again, we know here it, anisopoikilocytosis grading may not be as stringent like a schistocyst, where you don't have to actually tell you have 3% of anisopoikilocytosis. But what's important is you try to pick up all the types of abnormal RBCs. So especially in hemolytic anemias, it's important because you some of these, I mean, you want to know how much of polychromasia is there, you want to know how many fragmented cells are there, you want to know how many NRBCs are there, because it also gives some clue to the severity of the disease that we're dealing with, whether it's a thalassemia or something else. So giving some kind of an objectivity to the ever subjective hemolytic picture is something that a digital platform can do for you. And all of this, just imagine it's all happening. It's not like you're making an effort, it's not like you're sitting with a slide and going on and on, trying to figure things out. It's all available for you quickly on your software, for you to quickly see and grasp and calculate as to what you have to do next and report. And this is a case of sickle cell anemia. Again, sickle cells again have very strict criteria. You have to know, differentiate them from maybe erythrocytes or other fragmented cells. And this was a case of sickle cell anemia. It had a lot of target cells as well. There are a lot of microcytes, as you can see, and some NRBCs. And this is a case of dimorphic anemia. So I'm not trying to, make this a case discussion about finding what it is. I think some of these cases are obvious. I'm just trying to tell you that, the way we go about reporting it can be much quicker and much more accurate and more efficient if we have this kind of information available on our computer. So this is a dimorphic anemia. Obviously, when you see the histogram, you can see that there is a hump and clearly a dimorphic picture, and also how beautifully the image analysis has also picked it up and is showing you just about the same thing that you can see for yourself. And this is a malaria parasite. Again, a good staining is obviously important over here. I think all of you would be thinking, if these images look so fantastic, then what's going on? And there is no doubt that the image quality, whether it's a smear preparation, I mean, it starts from how we, the sample being as fresh as it can be and without any kind of artifacts. It has to be well smeared, preferably an automated smearing, preferably an automated staining, because you don't want interferences, because if your smear is going to have a lot of artifacts, you're going to throw the machine completely off, and it's a waste of everybody's time and effort at the end of it. So malaria parasite, again over here, you can see some, there are some gametocytes in the right bottom panel, and this is a case of a Plasmodium vivax. And this is another case where it was a case of refractory anemia with absolutely no clinical information, just a routine CBC was asked. I'm not sure how many of you are familiar with this, with reading a flow cytometric analysis of the scatter plot, but if you look at the site scatter on this particular case, the neutrophils have a very low site scatter than it should usually be. So that itself should give you a clue that the granularity of the neutrophils is reduced. So obviously a low site scatter means a lesser granularity, and the neutrophils have not really clustered where they should ideally be. And he's 79 years old, he's got refractory anemia. At this stage itself, I would in fact try and go back and look at some research parameters on this particular cell particle analyzer to see if it's giving me some more information about, some more clues or information about some kind of abnormality that's going on. What I did in this particular case was I found the scatter plot absolutely abnormal, and I thought the monocytes also looked very dense. I mean, I wasn't sure if they were all going to be monocytes and also the distinction between the lymphocytes and the monocytes region over here, if you see, it's not completely delineated. There are a lot of, there's a sort of haze between the lymphocytes and monocytes, perhaps indicating that there are cells of varying sizes, probably abnormal shapes also. Are we really dealing with lymphocytes and monocytes here, or something else, something fishy is going on, is what we have to discern. And yeah, and this, so the new X and new Y, that is the side scatter and the side fluorescence, were low, like I told you. But I'll not go into that because I'll be compromising on time. So when we saw this on the image analyzer, the neutrophils looked, first of all, and look at the number of lobes. You know, they're all band forms. They're all like looking like pseudo pelgohuic kind of cells. The cytoplasm is pretty much washed off. There are hardly any granules. They're perhaps even smaller in size. Obviously, there was dysgranulopoiesis, and there was an occasional abnormal. There were abnormal-looking cells, and some of these were myeloblasts, very occasional, but they were there. And there were dysplastic erythroid cells in the peripheral blood. They were not only NRBCs, they were also dysplastic appearing. And there was platelet anisochromia. You have these really large platelets, which some of them were, rather deeper staining. Some of them looked very pale, and they were all comparable to the size of RBCs. And some of them were very small as well. So there was a platelet anisochromia. We worked up this case, and that's why I'm showing you everything. We did a bone marrow, and bone marrow also showed a lot of hypercellularity with dysplastic cells, and a karyotype as well was done, and it was a case of myelodysplastic syndrome with excess blasts and abnormal karyotype. And just an interesting case where one of the aiding features over here, or factors, was our digital morphology analyzer, which when you have such clear-cut pictures and prompts telling you and guiding you that something is going on, then diagnosis becomes that much easier. 75-year-old male. See, in this case as well as the next one, both are cases of where the total count is on the lower side. Just keep that in your mind. There are NRBCs as well over here. The platelets are normal. There is a bicytopenia in this case. Here we had a lot of blasts. It was a case of straightforward case of AML. There were our rods as well as other abnormal features of AML seen. So when there is a low total count, that is how much more time, especially when the abnormality, or if it is of cancerous nature, then doing a diff with low total count is not always easy. The repeatability is invariably very poor, but the decision making of next steps also highly depends on CPC. So this is where image analysis also helps us extract that many cells. If I want, I can send 2 smears and say I want minimum 500 cells. It's going to take around 5 minutes or 7 minutes for the analyzer to do it, but it'll do all that and capture those 500 cells and present it to you for you to analyze them at a later time. This was a case of, obviously on scatter plot itself, you know that a CML is going on over here. It was a case where the total count is more than 1 lakh with mild anemia and a mild increase in platelets, and there was a big shift to left, and all the types of immature WBCs, myeloid cells, were captured, and promyelocytes, myelocytes, and metamyelocytes, everything were easily captured and classified so that we can give a quick differential count, maybe an occasional blast. This was a case of CML in chronic phase. The next case, again, clearly the flow cytometer on the scatter plot is showing some kind of an abnormality with a lot of NRBCs. We have a case of acute leukemia here. Almost all of them are blasts, and maybe perhaps I don't find any blasts with or rods over here. So how a digital analyzer can help you with low count or a high count, and can equally de-stress you from the manual stress of counting them in either of the cases. So, and reducing the inter-observer variability by improving the overall repeatability and precision. And of course, there is no doubt that it saves a lot of time for us. This is another case where there is a mild abnormality on the scatter plot, 22 young female. There's no reason to believe that something, with this mild leukocytosis, one would think that it could be of viral or a bacterial infection. And we have a normal hemoglobin and platelet. Most of these cells over here are transformed lymphocytes. So you find those lymphocytes with abundant cytoplasm and the skirting and the different shapes of WBCs, but they're all benign. They're just reactive in nature, and it shows the classical, what we call as the ballerina skirt appearance. The advantage is you find something like this, you can quickly ask your patient to take the next steps, whatever be the test, gold standard test that is recommended for EBV infections, and determine whether it's a case of EBV virus. In this case, yes, it was an infectious mononucleosis. Just to give you an example of how a different viral infection like our friend dengue with NS1 antigen positive looks like on the digital analyzer. And another case of a 60-year-old female with anemia for evaluation, and the total count is slightly increased. The hemoglobin is 7.2, and we have a very high MCV, suggesting a macrocytic anemia. Here there is hypersegmented neutrophils, which is helping us with the diagnosis, identification, and a diagnosis of macrocytic or megaloblastic anemia, possible megaloblastic anemia that can be reported by viewing it. And it also gives us a gradation or a grade of the level of macrocytosis or the size variation that there are in the RBCs. And some spotters, just some nice cases where there is neutrophilic toxic granulation and vacuolation. This is a case of platelet satellitism, and this is just a body fluid of a pleural fluid where a cell count, cell type was asked for, and we see that there are just so many neutrophils. It was more like pus-like kind of fluid with sheets of neutrophils on the analyzer, and this is a case of a lymphocytic. I'm sorry. This was a case of sheets of lymphocytes. I'm sorry. Sheets of lymphocytes where the ADA counts were very high and the TB-PCR was also positive. LDH was positive, and there were sheets of lymphocytes. On the higher magnification, we can see it. And this was a lymphocytic effusion with TB-PCR positive. This is a peritoneal fluid, a diagnosis of adenocarcinoma positive for malignancy was made. There's again another spotter of Mets breast cancer. And here is a spotter of a B-cell lymphoma in a pleural fluid aspirate. And a case of fever, a 47-year-old fever with headache and shortness of breath and whatnot. And a CSF analysis was done. And these were the types of cells that were found. And it was a diagnosis of histoplasmosis. So in short, I think I tried to make a very similar point throughout my presentation. And what was that? A few points rather. One is we have seen how we can bring in a partial automation in smear review. And what it does to us is it saves us a lot of time for review of smear. And it also helps us use the saved time and effort in more complicated cases. Like Sir was saying, I think a lab has many more challenging things going on where you can kind of redistribute your bandwidth and your effort. And also the image quality is remarkable. It depends on the type of software that you use. And there is a reduced inter-observer variability, better utilization of available resources, like I just mentioned. Remote access, I think here is one of the most important things about using a digital platform is always collaborate better with your colleagues and experts. And the traceability of results at every individual cell level is available. The images can be archived and stored for a later use. It can be used as a teaching tool for technologists or even for pathologists, and as well as for competency assessment.
Welcome everyone to this, as I said, a very complex topic which has been given to me as artificial intelligence in histopathology. This lecture can go on for at least 8 to 10 hours if I start speaking on it, but I have tried to concise it within 50 slides. It's a very complex topic since it requires a lot of programming. It's more of an IT and less of pathology in it. But of course, that IT is helping us do the pathology in a better way. So I've been given this topic, just a minute, yeah. I'll just put on my laser pointer. Okay, so this topic will be covered in a very simplified manner, and it will have the introduction, what is an AI, what is a machine learning and its type, what are the deep learning, what is the history of AI, just a brief of about 1 or 2 slides. We should know how it started and where it's going at the present moment, and why we require AI in pathology or histopathology, to be very specific. There are certain applications in histopathology which AI is being used, and whatever application I show you, they are currently in use and can be used in day-to-day diagnosis by slides and histopathology. So in the end, we will discuss the challenges. Everything is not a pro, it has its con also, and the take-home message to finish it off. So we will go in a very simplified manner. So what is an artificial intelligence? So artificial intelligence, in a very casual definition, is field of a computer science which makes machines perform like humans. Like what? Like it can perform learning, problem solving, planning, reasoning, and identifying the patterns and predicting the results. So that is what an artificial intelligence is. So artificial intelligence broadly comprises of machine learning, which in turn comprises of deep learning. All these together is a part of a segment of data science because it's all about data assimilation, data calculation, and then the output. So this is in a simplified manner. Artificial intelligence has a machine learning and has deep learning. I'll take each one of them. So what is machine learning? Machine learning is it is a type that provides computers with the ability to learn without being programmed. So you don't require a programming. So what you do is you take a data. Now, what is this data? Whenever I talk about data in histopathology, it's the image which has been clicked from the slide. It has pixels. It has certain data which resides in the pixels. Now, this pixel has been labeled saying that this is the region of interest and this is not the region of interest. And it is sent through a machine learning algorithm. Now, this machine learning algorithm, there are many softwares which actually help machine learn, and it is a computational learning experience by the machine. Some are like Python. So the moment the data is sent through machine learning algorithm, the algorithm is designed in such a way that it gives out an output, what is required. So the machine learns how to take in the labeled data and how to give out the output. So if the moment the machine learns, you're given a data which is unlabeled or it doesn't have a region of interest, it automatically calculates from the labeled data, compares with the unlabeled data, and gives you a prediction whether this is a tumor or not a tumor. So this is what a machine learning is. So it predicts the outcome of the data. So in a very simple way, if you're given a fruit basket which has multiple fruits of different shapes, colors, and sizes, the machine analyzes the data and it finds a pattern. This one is bigger, this one is red in color, this one is small, this, that. So it finds a pattern, it predicts and it decides and it segregates. Now, suppose it makes a mistake in prediction or decision. There a human intervention is required, which is called a feedback. Now the human corrects the machine, it learns from that mistake, stores it in memory, and next time that mistake is never repeated. So it keeps on learning from its mistakes, and that's where the AI is leading us to the sci-fi zone today. So what are the different types of machine learning? It has a supervised learning, it has an unsupervised learning, and it has a reinforced learning. This is the new one which is coming. So what is a supervised learning? It is very simple. You have a data set which is labeled in the sense that the pixel has been shown that this belongs to a tumor, and the machine learns that from the labeled data set that this is a pixel which belongs to a tumor. In unsupervised learning, it is non-labeled. There is no marking of region of interest. The machine learns in its own particular fashion by identifying a pattern. Now, reinforced learning is the machine learns on its own. It becomes smarter. It makes mistakes. It requires a feedback. It learns. It corrects itself. And next time, it will keep on doing this till it becomes perfect. This is what the stage is today. We are into reinforced learning of machine learning. So let's explain what is a supervised learning. If I have a picture of an apple and I send it through an algorithm in the computer, and I tell the algorithm, these are apples, it will make on its own the defined algorithm and a predictive output by looking at the shape, size, color. And when I send in a non-labeled data, that is a picture which is of an apple later on, the model itself will suggest it's an apple. So this is a supervised learning where a known data and a known response is fed in to make the computer learn and give out the prediction of the output from the unlabeled data. It is very simple. It's called supervised learning. How about unsupervised? I gave you an example. You have a basket of fruit which has different color of fruit, shapes, sizes. Now the computer, the algorithm recognizes it has a pattern. So it starts segregating the data according to the pattern which it sees. So apples are segregated in a different way, mangoes different, pear different. So it forms an algorithm by itself, and this is called an unsupervised. So what is the difference between supervised and unsupervised machine learning? So in machine learning, the situations which we give to the computer is called an output. And the solutions or the predictions which you get out of the computer or from the machine is called an output. So we have an input and an output. So in case of supervised machine learning, you need to have a labeled data. As I explained, the data has to be marked with the region of interest. The pixel has to be marked with the region of interest. It's a very tedious job. Person has to sit down and mark each and every area or each and every pixel for that region of interest. It requires a direct feedback. As I said, a person has to sit down and do it, and you get a predicted output. Okay, you wanted this tumor, you will get this tumor after the end of learning. But in case of unsupervised, as I told you, you don't require a labeled data. You do not want a person who sits down and label it, but it judges through a pattern. It finds a structure, hidden structure in the data by itself, and it gives out the results. So non-labeled data, no feedback, and it recognizes a hidden structure in the data. That is what is unsupervised. Yes. Okay, we come to reinforced. Now, reinforcement machine learning is a very complex machine learning where different algorithms are used and fed in the machine as the basic algorithms. So what happens is, now you have a picture of an apple, which the machine doesn't know this is an apple. It makes a wild guess saying it's a mango. So you just correct it saying wrong, it's an apple, it's not a mango. And the machine immediately recognizes the mistake and corrects its algorithm, basic algorithm. And then it marks it as an apple. And next time you input, it will find out this is an apple and label it as an apple itself. No need for any feedback. It has become smarter. It has become almost like a human. So this is what is being shown in the sci-fi movies nowadays, that robots are becoming smarter and smarter and they learn by themselves. This is called reinforced machine learning. So these are three different types of machine learning. I went in a very simplified manner, but if you look into each pocket of this explanation, there is a complex calculations and statistics which are required to be put in to get the desired results. Now, I'll give you an example. So if you take out an apple, the red color in the apple is coded by the hex color input of the computer. It has a number in the computer. So those numbers are placed all around the apple, and the machine recognizes this is the red in color, and it gives us an output with the shape and the hex number given to it that this belongs to an apple. So there is a complex calculation which takes place inside the machine before it gives out the results. So let's come down to deep learning. So deep learning is still a very, very complex part of artificial intelligence, where actually the machine develops a brain and it works like a brain because it forms a neural network. Now, how does this neural network? This is an artificial neural network which is formed by multiple codings and algorithms done in software for a predictive output in every layer. I'll just explain it to you. So deep learning is a subset of machine learning in AI that has networks capable. Important part is networks, which are capable of learning unsupervised from data that is unstructured or unlabeled. Now, if you have looked into the unsupervised part of machine learning, it had a structure, and that structure was understood by the machine and the results were. But in this case, it is so complex that even if it is unstructured or unlabeled and it is unsupervised, still the results come out. So it is also known as DNN, which is Deep Neural Network. So what is this Deep Neural Network? Let me give you an example. This is the simplified version of DNN. It has about 3 layers, maybe 5 of them, but the middle layers are called the hidden layers, the orange ones. So you have an image. This image, like a histopathology image, this image is clicked, but at a very high resolution, and the pixels are broken down. These pixels are fed into the computer. Each pixel is a data. That is called the input layer. That is the image. It is broken down into pixels, fed in. And the first set of pixel data is being analyzed by an algorithm. Suppose you have a pixel of a nucleolus, which is hyperchromatic. That one dot in hyperchromatic is picked up and analyzed and says this is hyperchromatic dot, and it passes on to the next hidden layer where still complex calculation takes place, looking into the regularity of that hyperchromatic dot, all those things. And finally, when the results come out, all these pixel by pixel data, which is filtered through these hidden layers, come out as a output. And this output actually comes out as what is desired. So it can actually segregate whether it's an oligodendroglioma or it is an astrocytoma by just looking into pixels, running it through algorithms, doing complex calculations, and assimilating the data at the end and giving out the output. So this is what a DNN looks like, deep neural network. This is where the world is moving now. So I'll give you some examples of DNN later on. So as the lecture goes, every lecture has some kind of history attached to it, even artificial intelligence. The term was coined in 1950s first. The machine learning was coined in 1980s, and deep learning is very new term, as new as the last part of the decade which went. So in 1950, you must have heard of a test called Turing Test. Alan Turing, he actually made computers behave like humans and could become judgmental and give out the results. He used this in a particular fashion in Second World War to break German codes. So this was called a Turing test, where the artificial intelligence was first started. But 1956, the term was coined by John McCarthy, where he devised the term as artificial intelligence by using a high-level programming language called Lisp. So let's not go into detail. So just a terminology for that. So in 2016, Anger Mueller, actually, it is that recent. In 2016, actually, the deep learning method was widely used to bring out the genomic and biological problems such as molecular trait prediction, mutation effect prediction, cellular image analysis. So this is a very recent thing where deep learning has been used to bring out the genomic probabilities of a tumor. In 2017, FDA finally gave a go-ahead to Philips PIPS, which is called Philips IntelliSite Pathology Solution. And it said this is the first system in the world which will be used for primary diagnosis. Primary diagnosis means it does not require an observer. You just send in the slide and it tell you whether this is a ductal carcinoma, what type of ductal carcinoma, and if you're given the IHCs, it will do scoring on its own. So it's called a primary diagnosis tool, which is called the PIPS. So it was done in 2017. We are not very far off, and a lot of companies have started acquiring this, and a lot of countries, a lot of cities in India also have got this system in hospitals and labs. So why do we require artificial intelligence in histopathology? So if you look into histopathology, it's a huge amount of data. Data in the sense that it is a picture. It's a huge picture which has multiple pixels in it. It's a huge data, and there are a lot of patterns in it. Anybody who does histopathology big time will fully understand there's a pattern to histopathology by which you give a diagnosis, always. And of course, in some countries, there is an acute shortage of pathologies with increased workloads. AI always helps them. And as the years go by, the cancer screening programs are increasing and generating more and more workloads. Plus, the testing is becoming more and more complex. They are acquiring molecular genetics or genomics with histopathology, and this takes a lot of time. And I'll show you how AI can actually start predicting mutations in the gene by looking into images, your slide images. So let's come down to applications of artificial intelligence in pathology. This is, before we start all this, there is a whole big subject of digital pathology, which I am not touching. It's a lecture by itself. And that's one of my favorites. So this is where AI starts in histopathology. So what is this digital pathology? Digital pathology is a simple tool by which your glass slides are converted into high resolution images. Now, how does that happen? So you have these scanners sitting, you've put in their slides. If anybody must have seen, these slides are scanned by the cameras which are fitted into the digital scanners, and each part of that slide is photographed, and it is photographed in a very quick succession. I've seen scanners doing 15 mm to 15 mm in about 40 seconds. So they click the images, and these images are immediately the moment they're clicked and the next one is clicked, it is joined together. That's called stitching. So that stitching happening, and then you have clicking and stitching and clicking and stitching. It forms a large image which runs into GBs of data. That image size can be anywhere from 2 GB, 5 GB, or maybe more, because it has got so many pixels in it. And this is now then exported out to the server, which sits with this kind of an image file. And this server can be, again, the data can be extracted from the server to give out the diagnosis by pathologists from the internet locally for consultation, or you can use this image to actually train and use it for machine learning or deep learning. So this is what digital pathology is, and this is the start of AI is by digital pathology. So let's take an example. You have a database in GDC. GDC is basically National Cancer Institute information in US. It's a cancer registry sort of thing. And they have a genomic database and huge set of data. You can also go there and have a look at it. So you download it. It's crowdfunding. So you download these images, divide it into 3 sets. Now this image has a tumor area and non-tumor area. So you pick up the tumor area, mark it as a training set. Each pixel, you label it as tumor, 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 just for an example. And you take on a validation set. Validation set is you label the tumor and the background set. Now this training set and validation set, when they are fed into an algorithm and the machine is told to bring out a prediction, it will definitely bring out that this is the tumor area, this is the non-tumor area. And when you put in a test set is where the data is not labeled by tumor or non-tumor. It immediately requires this, it immediately comes back and tells you that this is the tumor area and this is not the tumor area, and gives out an imprint which looks like this. This tumor area is highlighted as blue, non-tumor area is orange. So it can actually identify a tumor by training. So artificial intelligence is being widely used in breast pathology. So this is the biggest field in which artificial intelligence is being used now. So it has its own diagnostic applications. It has its own prognostic applications. Now in diagnostic applications, mind you, all these things which I am telling you here, they are algorithms already made for this, and people are using it in day-to-day reporting nowadays. So you have primary tumor detection, you have metastatic deposits detection in lymph nodes. You can have breast cancer grading done by machine learning. You can have breast cancer subtyping. Different types of breast cancers can be done by machine learning. You can assess the tumor microenvironment. You can look into the receptor status and do the scoring automatically. And the prognostic application. So it will tell you what is the prognosis of this tumor looking into the morphological features, how aggressive it looks, how plain it looks, and what are the microenvironment around it, what would be the prognosis. It can actually start telling you what would be the prognosis. And prognosis significance are different peritumoral elements like the amount of lymphocytes. It will label all those and tell you how this tumor will behave. And of course, nowadays people are using it to find out the genomic mutations and make precision medicines. So it can actually tell you that there are mutations, these particular genes. Looking at the photograph, the algorithms are so complex. So these are all being used in the primary care nowadays. So in 2017, Rishikesh in IIT Kharagpur, he took out about 175 images out of 37 breast samples, and he sent it through a GPU. GPU is a graphic processing unit. It is where the heart is and the brain is, where it processes the images. And it actually made the system learn to give out benign versus malignant. You'll be surprised. The output was with 89.7% accuracy. If the FNAC image is fed in, it can actually tell you it is benign or malignant with 89.7% accuracy. This is in 2017. It can still be done and it still exists. Now, this is a very important AI development which happened in 2018 in California. It uses the platform, Google platform. You must have heard. And there, 160 normal and 110 metastatic lymph nodes. Whole slide imaging was done for training. And the output was required whether the lymph node has metastasis or no metastasis. And the accuracy was 93.8%. You can imagine when we look into the slides, about 30 to 40 lymph nodes, and we keep on screening the lymph nodes for metastasis, it can be done in a jiffy with a 93.8% accuracy by machine learning. Now, this was way back in 2013, as early as that. So you can actually grade the tumor by mitotic detection and count the mitosis and tell you with an accuracy of F1 score of about 0.782. The highly accurate one is 1. So it's as close to that. It is 0.782 accuracy. You can actually detect mitosis. It all requires training, repeated training, and subsequently the reinforced machine learning comes in and it automatically learns and starts labeling the areas which are showing mitosis. Now comes the lung cancer. In lung cancer, Teramoto et al. In 2017 actually took FNA cytology smears. And those who report cytology can understand how it can become difficult at times because of the background. He used this algorithm to classify successfully adenocarcinomas, squamous cell carcinomas, small cell carcinomas with an accuracy of what 71.1%, where the human intervention did that with 62.1%. It was better than human intervention. It can pick out the images. As you say, this is an adenocarcinoma image automatically picked up by the machine. And this was not classified. So there was some debris around it. This is a squamous cell picked up by the machine. This is a small cell carcinoma picked out with the machine. So it did better than what the humans did. Of course, there are limitations to that. Now, the latest deep learning which has happened has absolutely replaced everything. You give out a section, the computer can tell you whether it is pathological, non-pathological. Pathological is malignant, benign. In malignant, whether it is adenocarcinoma, squamous cell carcinoma, or small cell carcinoma. As you can see, this is a machine algorithm detected an adenocarcinoma in the lung sample. This is a squamous cell carcinoma. This is a small cell carcinoma, clearly done very well by the machine. It can tell you it is a tuberculosis, pulmonary tuberculosis. It can tell you it is an organizing pneumonia, and it can tell you this is a normal lung. Nothing is left here. So the machine has adapted everything and started identifying the regions of interest. And this is another big step in deep learning, where this study was used by Theodore, and he actually found out that he can train the machine to bring out the prediction of the mutations in the genes. He used STK11, EGFR, FAT1, SATBP1, KRAS, and TP53 gene mutation. He saw the patterns, and the machine could bring up the pattern and tell you that this pattern will have EGFR mutated, this will have KRAS mutated, this will have TP53 mutated, with an accuracy of 0.733 and 0.856, which is a very high accuracy without doing a molecular testing, just by looking into the patterns. So this is how deep it has gone at the moment. Now, prostate cancer, this is another FDA, it's got the FDA approval. As people who we all report prostate cancers, we know how difficult it is at times to do a Gleason grading because of different tissue bits and different morphology in every bit. And so this has got an FDA clearance. It can actually tell you with a high accuracy a Gleason grading, and whether tell you in a prostectomy sample whether the tumor is present or not present. Just put in the slide, it will label the area of tumor, and it will tell you what the Gleason score is. There is an algorithm to that, and the algorithm was able to differentiate between Gleason 3+4 and 4+3 slides with a 75% accuracy. And it's let me tell you, it becomes difficult at times for a human being to do that. So you can actually quantify the tumor morphology also. So this is the study I'm telling you. There were about 1 to 4 patients, 5, 7, 5, 9 biopsies were taken, and the training was done, and the deep learning system was trained using this data from 1 to 43 patients. And you'll be surprised that the system outperformed 10 out of 15 pathologists by giving out the Gleason score and telling you that there is a tumor in this. So this has got an FDA clearance now. It has been installed in various hospitals in the country today. And this is the quantification of tumor zone in radical prostatectomy. You can see that the tumor area is clearly labeled by the algorithm. This is the non-tumor area, and this is the tumor area. And this the area also is calculated. This is how much the tumor is. So you can actually quantify the tumor. Brain cancer. So Atterson et al. In 2015 took that challenge, and he fed in images which can, through the algorithms of machine learning, that can actually identify glioblastoma multiforme from a low-grade glioma with an accuracy of 96%. So 96% of the times the machine was able to tell this is a GBM or this is an LGG. Now, further going down the line, he again supervised the algorithm to differentiate between grade 2 and grade 3, but that accuracy was 71%. Still, it's a good one. So this is another algorithm which exists, which can be used in your labs. So how it is done, as I told you, that you need a label training set. So it has the normal brain. Somebody has to tell this is the normal brain. This is the GBM. This is the metastatic. And you have the unlabeled data set, which is the tissue which you want to analyze. You feed in through this DNN. It goes through multiple statistics and multiple equations and brings out the area of interest, saying that this is a GBM or this is a metastasis or this is a normal brain tissue. So this is a framework which is being used currently. So, but in 2020, time of the COVID, and this person, Holon, actually devised an algorithm which can differentiate every pathology in the brain. It can diagnose a malignant glioma, a low-grade pilocytic astrocytoma, lymphoma, ependymoma, metastasis, medulloblastoma, meningioma, pituitary, gray matter, non-diagnostic tissue. Everything can be diagnosed if you send a slide through this machine learning algorithm. This is a superb feat which has taken place, and it can be used. Ovarian cancers, again, this is in 2018, Wu et al. He used this algorithm to classify ovarian malignancies and mark the tumor area with an accuracy of 78.2%. So you can actually send in the slides through digital scanners and wait for the results to come in and screen the images and actually tell you what classification the tumor belongs to. Now, this is another technology which has come in. It's called DeepPap. Now, this DeepPap is done on LBC smears. Now, in 2017, Zhang et al., he devised an algorithm through which he did a training, and that can actually tell you whether it is a benign or a cancerous cell, or benign or a cell which is atypical, and it can actually tell you whether it belongs to an L cell or an H cell with an accuracy decision of AUC of 0.99, which is close to 1. So this DeepPap techniques are available. It can be used to screen high volume slides. Now, the best part a machine learning has is for the IHC application. As you know, the purpose of digital pathology, artificial intelligence, for me, machine learning and deep learning, for me, it is bring out the subjectiveness in the diagnosis and make everything objective. As we know that IHC scoring can become a problem at times. There are multiple case scenarios you have also observed. So this machine algorithms can actually quantify Ki67, P53, cytoplasmic CD68, membrane markers, and HER2/neu, ERPR, you name them, PDL1. You know, all these things can be actually quantified with a high accuracy and give you the score, and which will help in decision making. So this is an example of PDL1. As you know, people who do PDL1 scoring, you know that there are very non-specific staining areas which are like tumor cell membranes, in particular macrophages, lymphocyte, and necrotic stromal regions. But if you run this through this AI, which was formed by Humphreys et al., it will actually give you the correct score of PDL1. It can label the tumor tissue from the non-tumor tissue, and the non-tumor tissue also, it can tell you which one is significant and which one is non-significant staining area. And the tumor tissue is correctly highlighted, and you will get an accurate score coming out of it. So IHC, you name Ki67s, those algorithms were the first one to come in. ERPR, HER2/neu scoring, all these are available nowadays. They come bundled up with multiple digital scanners, and you just have to ask them. we want ERPRKI reporting, and they will give it to you. Of course, they will charge you for that. And you run your slides through it and you get an accurate score coming out of it. People who screen the slides to take it for molecular genomic sequencing go through a difficult time when you have to quantify the tumors. Now, this is a machine learning algorithm which is called tissue mark. This tissue mark, if you run through your slides, can actually quantify the amount of tumor and the area of tumor. And you can actually tell your molecular biologist, this is the amount of tumor you have. You go ahead and do the testing on it. So this is called tissue mark. You can actually quantify the tumor tissue before you take it out for molecular biology assessment. These are some of the companies, the list keeps adding up nowadays. PathAI, Google AI Page, Indica Labs, Bosch, and Philips has come in a major way. You have other equipments also there. So just for your information, you can go to each one of these websites and look into what AI they have done. What are the challenges? Now, challenges, everything doesn't have a pro, it has a con also. In our country, as you know, that everywhere, I suppose, there is a pre-imaging technique challenge, which is the staining of the tissue. Now, this staining can be dark, light, it can give rise to wrong pixelization. But the scanners have improved so much nowadays. A couple of months back, I saw a scanner where they broke the slide into 20 pieces, put a cover slip on it. It could still sense the tumor tissue. It can still mark the region of interest. And they have become so good nowadays. So I think with time, this limitation will be going off. There is something called Z-stacking. So this Z-stacking is being used in cytology. It's multi-layering photography of a cell. So the cell is actually shot in 3-dimensional. And these are available with all these scanners which are common. So if the tissue is folded, you can actually feed it through a Z-stack and get an accurate tumor content in that folded tissue. So there's something called Z-stacking. I just want to tell you that. Now, as we are progressing towards AI, we require more and more labeled data. Now, labeled data is a painful exercise. Most of the data for most of these tumors are not labeled, and we don't have very good training images for this label. And if you take in crowdsourcing data, like just I told you, the GDC, if you take in data from there, you can have some background knowledge. Background knowledge in the sense that you can have some mixed signals coming out from the tumor and non-tumor zones. So that also creates a problem. And all tumors cannot be taken up for AI at the present moment. There are cells like some sarcomas with a marked polymorphism can create a difficulty in AI because the algorithms do not actually yield out the correct results. So there are still challenges in tumor tissues. Okay, so as I told you that these are gigapixel digital images, and the deep neural network actually works in less than 350 pixels. But the image in total is formed by more than 50,000 pixels. And the deep neural network actually to write an algorithm requires less than 350 pixels. You can see the amount of complexity it requires. And if you look into a large image, it can give rise to a lot of complex calculations, which can take a lot of time. So see, the dimension itself creates a lot of problems. So the final one which comes in is the financial expenditure, which you have to do to take in machine learning. So as you know, currently the financial pressure is too much to adopt the WSI. Every hospital is pressurizing to go in for digital pathology. And as such, the GPUs are very expensive. So it's a very expensive solution at the moment. Now, lack of transparency, it is very difficult to convince the clinician why this tumor would behave badly and why this tumor would behave in a good fashion just by machine learning. And it is very difficult to make him understand. And you cannot actually establish a way to explain how the results have come out. So there is a lack of transparency. and interpretation. So, but what in the end, it is a little bit difficult to deploy the AI tools in practice. So this, when I think the pathologists will take these 3 decisions, key features to look into before they deploy. One is the ease of use. They should be able to use it very easily. I can tell you the ERPR and KI algorithms have become so easy. You just put the slide in, mark the area, and it does the calculation, give it to you. And what is the financial return of investment? For all the businessmen and pathologists who are involved in diagnostic setups, the ROI is very important. How soon will you get the investment out? Since it's a very expensive equipment you buy, a single slide scanner would cost anywhere from 20 lakhs to 30 lakhs. Multiple scanners will go up. The Philips one, which I was talking about, was any range of 3 crores or something like that. So it's an expensive modality. And you need to develop the trust also for the results which are coming out. And it happens with time. So the take-home message is AI will definitely not replace pathologists. I agree with Dr. Neeraj. He told us that initially. But we need to learn to adapt to the changing diagnostics. It will help you make your work easy. You will not be replaced tomorrow. That is one thing. So once a new technology rolls over you, if you are not a part of the steamroller, you are part of the road. It's better to adopt it, learn it, and start using it when it comes to you. Thank you.